And now let's turn it over to Jim.
Thanks, Connie. Yeah, I'd like to talk about why it's important to consider including an independence at home style home-based primary care practice in an ACO model now. And now is definitely the time has definitely arrived to do that. Next slide, please, Connie. We're looking at, I could see this, we started developing the Independence at Home program back in 2000, and I could see that the country was simply running out of money and couldn't afford the healthcare delivery system that it had. And we're now seeing that really coming to a head, because we see that healthcare costs are concentrated into a fairly narrow band of beneficiaries under Medicare and Medicaid, but this is also true under private insurance and Medicare Advantage as well. According to Johns Hopkins, 5 to 25% of Medicare to Medicaid beneficiaries account for 50 to 85% of the costs. But just as importantly, the bottom 50% account for less than 4% of costs. So some health reform models, including some ACOs that sweep in that bottom 50%, are going to have a very difficult time showing any savings. And when we got Independence at Home included in the Affordable Care Act, it was surprising to me to see that it is the only program out of 970 provisions that requires any level of savings. ACOs are not required to achieve any savings, but they do provide incentives for it. The concentration of these costs among a narrow band of patients is going to get worse because we have an aging population and a declining birth rate. Next slide, Connie. So we now see that the overriding issue today and for the foreseeable future in health reform is going to be cost reduction while preserving the quality of the health care that's delivered. And I've included a report of a panel discussion of leading experts on healthcare policy, and no one, at least in this town in D.C., doubts that anymore. And we're facing a major meltdown towards the end of the year here if there is a sequestration that goes into effect as a result of some of the budget legislation. Then we're going to see across-the-board cuts in Medicare. They won't be Medicaid, but they will certainly be in Medicare, and it will simply make matters worse. Next slide, Connie. So the question is, have ACOs proven effective to date in reducing healthcare costs? It's a fairly new model, and so the verdict is still out on that. But three principal concerns we see about ACOs are that they are relatively expensive to set up and operate. You can't determine or control the risk because the quality measures can vary from year to year, and the model is still being kind of refined. And the model itself is essentially unproven. The integrated delivery systems in the past that have tried this kind of approach have not always been successful. So if you look at what an independence at home style primary care model can bring to an ACO, we see that the home-based primary care model is relatively inexpensive to set up and operate. The risk can be controlled because it targets patients with known very high costs, and as mentioned, you can leverage a lot of savings by making a difference in a small percentage of patients. And as Rod was saying, it's proven effective in reducing costs in the past in the VA and other programs. Next slide, Connie. But as I say, I think independence of home and the home-based primary care really offers a really bright ray of hope for ACOs to show savings early on. Certainly, over time, ACOs may be more successful. But with the nice thing about independence at home is that it can produce, or primary care, home-based primary care, is can produce results almost immediately. And you see, even in the preamble to the final ACO regulations, there was a recognition by the CMS actuary that any savings to be achieved by ACOs are most likely to be achieved in the highest cost patient population. And the Congressional Budget Office recognized that in a report issued in roughly May 5, I think, 2005. There's general recognition that if ACOs are going to achieve savings, it's going to be among the higher cost patients. Next, please. So what value does the independence at home style house call model add? This was a quote actually from a congressional staffer who summarized it after I'd explained the program to her. She said, well, gee, you mean it's targeted, immediate, and proven? And so, well, that just about sums it up. So as you can see, it's targeted to the highest cost folks. It's an immediate, produces immediate savings and new and better services that are provided 24/7, proven in the VA context. Savings, as I said, are required. And then it has among, at least the demo, has among the highest savings sharing split for any program. Now, it has low startup costs and low operating costs. Now, the Independence at Home demo is certainly a demo under Medicare, but we designed the Independence at Home model to be a clinical and a financial model. So as Rod described, and also Gary, you can use that model outside of the demo and with any private insurance or Medicare Advantage plan or any ACO. Next slide, please. So as I said, it's both a clinical and a financial model. It doesn't do you much good to have a great clinical model if you can't achieve savings, but you have to be able to show the savings. That's one of the advantages of savings sharing computation. It requires the payer to tell you each year how much you have saved them. That is absolutely essential for future contracts. And the Independence at Home program is really based on the concept that you get what you pay for. If you pay for processes, and that was actually one of the original ideas behind ACOs, that they would improve the process by which health care is provided. We get lots of processes, but if you pay for savings, then you get savings. And as I mentioned, the IAH home-based primary care model should be attractive, and we're finding actually is attractive to all kinds of payers because they're all looking at the same problem. In the future, as of 2014, health plans are going to have their income capped. They're not going to be able to raise premiums as they have in the past, and they're going to have their cash outflow, the payouts, uncapped. They're going to have to insure people with pre-existing conditions. They can't limit the amount they pay out. They can't set premiums based on health status. So they're facing a difficult situation. Next slide, please. So sometimes the way I portray it is you could continue doing business as usual. You can put together an integrated delivery system or an ACO and continue to do provide care pretty much as you always have. There's certainly some efficiency to be gained by having a consolidated electronic medical record. But to achieve some real savings, it looks like to most folks, including me, that you're going to have to move some of this health care out of facilities into lower cost treatment settings. Next slide, please. And Independence at Home, home-based primary care gives you an opportunity to make a difference, to make a real difference in patients' lives. And it's probably one of the only areas today where you can provide services in a way that patients prefer. It's a rewarding way to provide care for practitioners. And because it achieves savings, then it's a methodology and a model that's favored by providers, by plans, by payers as well. With that, I'll turn it back to Connie.
Thanks very much, Jim. Well, last but not least, we want to talk a little bit about how the AHCP can help, especially to the ACOs who may not be members of the Academy. First of all, we can help you with networking. We can put you in touch with members who are house call providers, either through our located provider list, which you can find on our website, or if you call for our telephone number, 410-676-7966, we can tell you other members in your area. Members, we we would remind you that we have posted the list of approved CMS ACOs on our website. Also, this is the listing at CMS, and we'll continue to add as we know about more. And if you find more, let us know, and we'll put them on our website as well. There are, of course, Blue Cross Blue Shield and other managed care plans that are developing ACOs all the time. We also would invite everyone to come to our annual meeting, May 2 through 3, 2013, as a pre-conference to the AGS in Grapevine, Texas, which I promised, I haven't seen it yet, is a Dallas suburb. So it would be a good time to get acquainted and have more dialogue. We can also help you with publications. This is especially for the ACOs. I hope members know that these are there. Making house calls a part of your practice speaks to what Dr. Hornbeck is doing, which is having an office-based practice, but adding a house calls component to it. It goes through what the issues are and establishing it and defining the scope of practice that you're going to undertake. The soup to nuts field guide is our other resource that really does go through everything, including issues about employment versus contracting and all the other sort of major issues that come up in much more detail than the very brief making house calls a part of your practice. We also provide practice management technical assistance. For ACOs, we think it's very important to learn about what you don't know but may want to think through. We can give you referrals to websites, publications, and other written resources. We can think through with you and answer practice management questions such as billing, coding, revenue, the rest of that, and so forth. Through, as our members know, Gary Schwartz, who provides technical assistance as part of the overall AHCP offerings. And this is both for ACOs and for members. For membership, we would certainly encourage you, if you have as an ACO decided that you want to go down this road, we would really encourage you to have whoever your clinical providers are or the people who are leading the development join the academy. It will give you access to HCP's many benefits. This is the early adopters and early pioneers are all here, and we now have some middle adopters, and everybody has learned a lot and they've shared a great deal with us, so we wouldn't want you to miss out on anything. The website address is www.aahcp.org. For ACOs, please call me. We are going to make special discounts available. We know that you have different operating structures, so how exactly to do this may take a little discussion, but I'm right here every day. So give me a call and let's try to get you into the family. This is a slide that shows for further information. Please remember we have a website, IAH website, with different and related information. And here are the email addresses for all of us. The general email address for the HCP is listed, or my address, which is E.D. Rao. Gary Schwartz's is listed. Dr. Hornbeck's, Dr. Soriano, and Jim Pyle's addresses are also listed. I'm going to give you just 3 references, just in case you'd be interested in looking at something more. There is an overall article by Jen Hayashi and our current president, Dr. Bruce Leff, in a American Society on Aging blog that gives a good summary of the different styles of home-based primary care programs that exist and why they are similar but yet different. Dr. Soriano's program was mentioned in the Mount Sinai Inside. Her program is part of a large integrated healthcare system academic medical center program that has a number of initiatives underway addressing issues in trying to reduce hospitalizations, reduce readmissions, and take better care of particularly the homebound and home limited in the community. Same thing, Montefiore Medical Center, which was in a Modern Healthcare Research Insights article. There are, of course, many more, and, of course, many of these programs are mentioned. We're happy that a number of our members are part of ACOs now, and we certainly hope that that number will grow in the future.
Gosh,
So with that,
if
sure,
I could just add, also USA Today this week ran an article on the most significant health reforms implemented in 2012, and Independence at Home was the only demo that was mentioned, but it was mentioned very prominently as one of the most significant reforms and most likely to achieve reductions in cost.
Great. Okay, well, we have some questions to start things off, and please, everyone, if you have a question or a comment, please put it right into the on the sidebar of your screen right now, so that we'll have some discussion before we close this out. This is a question that I'd like to direct to both Rod Hornbeck and Jim Piles. This is from a larger home care practice that is spread over a number of ACO markets. Please address the rule that a PCP can only belong to one ACO. Also, what about the need to integrate with multiple EMR systems?
I'll take a crack at that. There are a couple of ways to deal with that. Particularly if you're going to take care of patients for a year or two, or if you're going to, which is a typical length of stay in home care, a year or two is an appropriate interval to be thinking of. How would you do that on behalf of multiple ACOs? Well, you can do it and bill for the service as a subcontractor to someone else in the accountable care organization. The ACO also has the issue of attribution. Remember, patients aren't enrolling in an ACO. Their experience is being attributed to the ACO. So with some creative billing arrangements, be careful, you have to have a lawyer involved. But so with some creative billing arrangements, you can actually be a contracted or a subcontractor for multiple ACOs.
Yeah, so Rod is right, and the limitation that the questioner is referring to is the restriction on patients participating in both the IAH demonstration and an ACO that is authorized by the Savings Sharing program. Now, there are other ACO programs like Pioneer ACOs and Advanced Practice ACOs, Advanced Payment ACOs, that are authorized under the CMS Innovation Center Authority. So first, you can, the prohibition on participation by patients in both types of programs only applies to the Savings Sharing Program ACOs. But remember, the Independence at Home, home-based primary care model is a care delivery and financial model. You can always use that in an ACO and not have it be part of the IAH demo, but you can use it as an approach in an ACO to negotiate with a managed care organization, to negotiate with a private insurer. You could even use it in an ACO for Medicare. You just won't get the savings sharing from the IAH demo, but you would get the savings sharing that is achieved by the ACO, and an Independence at Home model will dramatically enhance the chances of an ACO actually sharing in savings.
Jim, on that point, before I go back to you, Rod, do you want to clarify that somebody wrote in the question ACOs and IAH? You may want to reinforce what the relationship can and cannot be.
Yeah, there is an IAH demonstration for Medicare beneficiaries, and the programs that are participating in that can't participate in a shared savings program ACO, but they can participate in a Pioneer ACO or an Advanced Payment ACO. I won't go into, there's some technical details on how they can do it, but believe me, it can be done. Again, if you're just using, if a group of physicians or a physician practice or a portion of a physician practice wanted to use the IAH model in an ACO without participating in the IH Medicare demo, they could do that.
Right. And you may also want to mention that they are allowed to participate in ACOs put up by other people, Blue Cross Blue Shield plans and others, right?
Oh, absolutely. And that's where the demand in the future, I think, is going to be from these private insurance plans, because they're entering into a world they have never entered into before, and they all know where their costs are. So you can approach one of these plans and say, give me the profile of your 5-10% highest cost patients. I'm willing to take a little risk. I will guarantee you X% of savings a year, but beyond that, I want 80% of all savings beyond that. You could use the same model with a private insurer or a Medicare Advantage program.
Right. Okay, Rod, I've got two for you, and you can and you can take them in any order you wish. The first, how do you handle the need to integrate with multiple EMR systems in your experience? We have several people who've asked about this issue, which applies to virtually everyone.
Okay. Well, I think that we've looked a lot at technology and what its role is, and I think it's a diversion. I think every EMR that I've used, and I've been involved with installations of EMRs going back to 1992, believe it or not, and I have used four different EMRs, and every one of them has the capacity to incorporate a faxed document. So if a home visit practice uses one type of EMR, or is simply using Microsoft Office-based products to produce a clinical record, then that can be scanned, faxed or scanned into the EMR that the physician is using, who is the referring physician. Just treat it the way you would a consult with a subspecialist.
Now, what do you do about the hospital, which typically has a different, or hospitals, which typically have different systems altogether? How do you get notified of somebody being admitted and that kind of thing?
We have a hospital that owns a large number of physician practices, uses eClinicalWorks. We use eClinicalWorks. There are products available from eClinicalWorks that allow documents to be marked up with HTML and transferred from one EMR system to the next, or within eClinicalWorks, different owners, different tax ID numbers, but we don't use them. We don't find that they're particularly useful, so that the work product of the hospital EMR, or the physicians who are in the own practices, their work product is easily converted into a PDF file or simply printed and then faxed and scanned. It works quite well.
Okay, thanks so much. Okay, here's the second one. I want to learn how home-based providers advocate for advanced directives, use and report DNRO orders, and integrate with palliative care and hospice.
Well, let me deal with the last part of the question first. Most physicians that are making home visits are quite experienced with hospice and palliative approaches. In my practice, a significant number of the patients that I see for home visits are hospice enrollees, and I'm continuing to manage their care. So that's the first thing. The second thing is, how do you refocus on patient desires? And I draw your attention to the experience of the Sutter Health System, which is an integrated delivery system with 5,000 physicians, multiple hospitals in Northern California, and they have their own health plan and their own home care agencies and their own hospices. So they're a little bit different than what we're faced with in the real world, but they had developed a program called the Advanced Illness Management Model, which has been written up in Health Affairs. And what they did was very simple. They trained everyone who came in contact with the patient to be attentive to any hint that the patient wanted to shift gears away from curative treatment. So, for example, a home health aide coming into the patient's home to give them a bath or assist with activities of daily living is trained to be attentive to language like, "I hope I never have to go back to the hospital." Well, that triggers a meeting with the patient where that subject is delicately brought up, and then a care plan developed that reflects patient goals. The patient may, on reflection, say, "No, I guess I was wrong. Something like that happens. I really do want to go back to the hospital." Fine, no problem. That's okay. But a very significant number of patients, of all the patients referred from the hospital to home care in that program, hospice utilization increased 47%, and hospital admissions decreased 63%. So it can be done very carefully and very gently.
If I could add to what Rod said, because he's right on point there. I mean, our healthcare delivery system has, until now, has been designed principally for the convenience of the physicians and hospitals, it seems. And but the independent at home, home-based primary care model, it really is a truly patient-centered approach. It takes the primary care to the patient in the home, and one of the most valuable parts of it, from what the feedback I get, is it allows the physician to do the kitchen biopsy to see what the kind of environment the patient is living in to help craft a care plan that's suitable for the patient. And when we developed the Independence at Home program, our model, we had, with Rod's help actually, we identified 3 performance standards. One is minimum savings of 5%, which we discussed, good outcomes as measured by a minimal set of quality measures, but in addition, patient and caregiver satisfaction. And that goes to the point that Rod is talking about, where we provide the care that the patient wants, not the care that the doctor wants to provide.
Great. Well, now I have 2 other questions, and then we'll have Jim maybe one closeout comment. There are 2 sets of questions. Nurse practitioners and have written in asking, what about nurse practitioner-led house call programs? And a physician assistant has written in about another aspect of all of this. First of all, to be remembered is that nurse practitioner-led house call programs are just as much part of this as anyone else. There is no prohibition, and in fact, many of the current practices that we know about either have NPs as part of their as part of the physician-led practice, or contract with or have other arrangements with. And certainly nurse practitioners are welcome to make presentations to ACOs along with other styles of home-based primary care programs. The question from the physician assistant has to do with frequencies of visits and readmissions. And I simply am going to say that that we are in the process of gathering information now about styles of practice and frequencies of visits and that kind of thing in relationship to the IH practices. At the moment, we don't have any data to refer anyone in our membership base to, or the ACOs, but we certainly will have much more information within another month or 2 and make that available to everyone on our website. In the meantime, we would encourage you to network. A great place to network is at our annual meeting, but you're also welcome to use the listserv and other ways of communicating with each other. Jim, let me leave one more question for you. Any movement by CMS to allow practices to participate in multiple shared savings programs?
I haven't seen any movement yet, but I think that will come. They're still in the testing phase, and they want to make sure that they have clear distinction between these various programs to see what works. Even though the ACO is a permanent part of Medicare, pretty clear that if that model does not achieve savings and reduce healthcare costs, it's not going to continue. And if you look at the ways that health savings can be achieved, I don't see how any other model produces politically acceptable savings. You can't cut coverage because that's politically unacceptable. You can't cut reimbursement, or you're going to have whoever's reimbursement you cut all over you. You can't shift costs to the patients because they're too sick to pay any additional costs. So the principal way for the future, it seems to me, of significantly reducing cost is by doing what most of the European countries are now doing, and that is shifting cost of the chronically ill out of facilities and into the home.
Great. Well, we've reached the witching hour, so I want to thank our presenters so much. There are 4 questions, Gary, for you that I'm going to ask that you put in the next e-newsletter, which will come out on Monday. We are going to send you an evaluation. We hope that you will give us feedback, and we hope that you will call, write, or whatever if there's anything more that the HCP can do for you as you look at new forms of relationships and new ways of helping our patients. Thanks so much for coming, and I will now bring this webinar to an end. Goodbye.